We are live.
Okay. We welcome you all to the next session of the 5th International Ophthalmic Conclave on the Periocular Aesthetics, Precision and Perfection, the APSOPRS session. And just few hours left for the 360-degree around the globe in 36 hours, the journey with the experts in the field of oculoplasty, covering the latest advancements, techniques, and the best practices in the field. Before we start with the session, I would like to extend a sincere gratitude to all the esteemed faculty for making this conclave possible through different time zones, and your contributions are highly invaluable. I now request our moderator for the session, Dr. Milind Naik, sir, to please take over the session and walk us through this symposium.
Thank you, Rolika. Am I audible?
Yes, Dr.
Yes.
Milind.
Okay. Just let me know if the slides are visible.
Yes, but it's in the
Let
speaker.
me check.
Yes,
How about now?
perfect.
Right. Good morning, good afternoon, good evening to all of you. Welcome to the Periocular Aesthetics session. We have a wonderful session organized between AIOS and APSOPRS, and I would like to first invite our president, Dr. Kasturi Bhattacharjee, the president of APSOPRS, to say a few words to inaugurate the session. Kasturi? Is Kasturi there?
Thank you, Milind. Am I audible?
Yes, you are.
It's a real pleasure to see Dr. Rodriguez. So good evening, good morning, good afternoon, all the faculties, colleagues, and friends. It's really a great pleasure for me to welcome all of you to this special event organized by All India Ophthalmological Society, the International Ophthalmological Conclave. And it's such a heartwarming to see the distinguished gathering of the experts from the Asia Pacific Society of Ophthalmic Plastic and Reconstructive Surgery who have come together to share their knowledge, expertise, and the vision. So heartfelt gratitude to the organizing team, and also extremely thankful to all the faculty who have graciously taken the time to be here with us this Sunday evening, or I should say Sunday night for many of you. So thank you very much for your commitment and contributions. Your presence definitely adds value to this event, and we are deeply honored to have you as a part in this journey. And I'd like to mention that this session, that is the AIOS APSOPRS IOC session, is the first academic session we are having in the Silver Jubilee year of APSOPRS. So congratulations, all of you. And let's make the most of this opportunity to exchange ideas and spark innovation and strengthen the bonds within a community. So I look forward to a very enriching and inspiring evening ahead. So over to you, Milind.
Thanks, Kasturi. So my job now is to introduce our very eminent and prominent faculty. It begins with our chairpersons. Kasturi Bhattacharjee is the director and also the head of the Oculofacial Reconstruction and Aesthetic Surgery Unit at the Shankar Dev Nethralaya in Guwahati in India. She also is the current president of the APSOPRS. She is the president-elect of our national society, the Oculoplastics Association of India. And our next co-chairperson is Kelvin Chong, who is a professor and chief of orbital and oculoplastic surgery at the Chinese University of Hong Kong. He's the president-elect. Is a challenge. You cannot hear me?
Yeah, it's not very clear.
I think, ma'am, it's a network at your end. I'll help you out, ma'am.
Is it mine or is it Milind's? Just check.
I can hear Dr. Milind clearly, ma'am.
That means something is wrong with me. I can't hear him. Okay. Milind, you go ahead.
Okay. So apart from the chairpersons who will be coordinating and interacting with everyone, we have 4 speakers. Alice Go from Malaysia, who needs no introduction. She is the leading aesthetics and oculoplastics person in Malaysia. Trained with Bob Goldberg, is currently council member of the APSOPRS, and she's going to speak to us on the golden ratio in Epicanthoplasty. Stephanie Yang-Ming from Singapore, trained by Ganga, is the current vice president of APSOPRS, very active in the Asia Pacific and global region in oculoplastics and aesthetics. And she's going to speak to us about the Asian upper eyelid blepharoplasty. Kasturi, our very own president of APSOPRS, she will talk to us about types and techniques of lower lid bleph. And I shall be speaking on the aesthetic considerations beyond blepharoplasty. Our panelists, apart from Alice and Stephanie, who are also our speakers, are Yvette Santiago from Philippines, who is the current very organized and into brackets strict secretary of the APSOPRS. She's the head of orbit ophthalmic plastic and lacrimal surgery at St. Luke's in Manila. And Helen Liu from South Korea, who's the vice president of APSOPRS, and she is the professor at the Medical College CHA University and Seongnam. We also have 4 very prominent oculoplastic surgeons from the Asia Pacific region who would be speaking on a very interesting case presentations from their side, which would be discussed by the panelists. So these speakers include Purnima Stapit, who is the head of Department of Oculoplasty, Ocular Oncology and Prosthesis at the very famous Tilganga Institute of Ophthalmology in Kathmandu, Nepal. George Cheng is a consultant at the Hong Kong Laser Eye Center. Viviana Cho, a consultant in ophthalmic plastics and reconstructive at the Uijeongbu St. Mary's Hospital, the Catholic University in Korea. And Thi Tu Hien, she is in the Vietnam National Eye Hospital, consultant in oculofacial and reconstructive department. So here's the entire list of speakers, panelists, as well as the speakers who will be presenting their interesting cases. And we will, without any further ado, begin with the session.
Thank you, Dr. Millen. And may I now request Dr. Alice Go to come up with her talk on the golden ratio in epicanthoplasty.
Okay, hi everyone. Can you hear me?
Yes, Doctor.
All right. Okay, first of all, I'd like to extend my heartfelt thanks to Dr. Millen for the kind invitation. And I prepared a video presentation, so it highlights a topic that combines artistry and science, which aligns with the theme of this periocular aesthetic webinar, Precision and Perfection. So thank you for your attention. I hope you enjoy the presentation. Nice for this aesthetic harmony. Today,
Yes.
Welcome to this presentation on the art and science of epicanthoplasty. In this video, we will explore a revolutionary approach to planning surgical corrections by incorporating the golden ratio, a concept rooted in mathematics and universally recognized for this aesthetic harmony. Today, we will discuss how applying the golden ratio helps achieve balanced, natural, and stable results in epicanthoplasty. Let's dive into this fascinating intersection of art and science. So what is the golden ratio? The golden ratio, approximately 1:1.618, is a mathematical proportion found in nature, art, and design. It has long been associated with visual harmony, from the spiral of a seashell to the proportions of the Pantheon, and even Leonardo da Vinci's Vitruvian Man. In visual aesthetics, the golden ratio has been applied to measure proportions that are generally perceived as attractive, from the width of the face to its length, to the spacing of the eyes, and the proportion of the lips. This ratio provides a framework for assessing balance and harmony. The epicanthal fold is an excess skin fold in the inner eye corner commonly seen in East Asian populations. This fold partially covers the inner corner of the eye, making the eyes appear smaller and less open. While aesthetically significant, excessive correction not only risks compromising the natural aesthetic balance, but also impact functional outcomes. This emphasizes the importance of a precise and scientifically guided approach to achieve harmonious and effective results. Epicanthoplasty is a cosmetic procedure that eliminates the epicanthal folds to lengthen the inner part of the eye and create a bigger, brighter eye appearance. There are various surgical techniques described in the literature. However, there is no standardized formula to calculate the amount of correction in epicanthoplasty. Here, I would like to introduce the application of the golden ratio in epicanthoplasty surgery. My hypothesis is that the golden ratio can serve as a guiding principle for epicanthoplasty. By measuring the corneal size and the distance to the medial canthus, we can calculate the ideal amount of correction needed to achieve proportion that align with the golden ratio. So how do we apply the golden ratio in practice? This method can be utilized as a valuable assessment tool during patient consultations, surgical planning, and post-op assessment, helping both the surgeon and patient visualize the desired outcome. So here's how it works. Step 1, import the patient's photo into a tool like PowerPoint or any imaging software. Ensure the image is clear, centered, and accurately scaled for precise measurements. Step 2, use a golden ratio rectangle, which can be easily downloaded online. Align the longer side of the rectangle to the corneal diameter, which is the horizontal measurement of the visible cornea. Step 3, the shorter side of the rectangle now represents the ideal distance from the corneal edge to the medial canthus. This is the proportional distance based on the golden ratio of 1:1.618. Finally, you can measure this ideal medial canthus to corneal distance and compare it to the patient's actual anatomy. While this step isn't mandatory, it provides an objective framework for assessing whether epicanthoplasty is appropriate. By using this method, you can better communicate the rationale behind the procedure to your patients, helping them to understand how the corrections achieves both aesthetic harmony and functional balance. By applying the golden ratio, we can also demonstrate when an epicanthoplasty has been overcorrected. If the medial canthus extends beyond the edge of the golden ratio rectangle, it indicates that the correction exceeds the ideal proportion. Overcorrection in epicanthoplasty can lead to complications like impaired eyelid closure or excessive dryness. By using the golden ratio, we can avoid such issues. This balanced and precise approach underscores the importance of integrating science into surgical planning. In surgical planning, we can utilize the golden ratio to determine the exact amount of correction. This way, we achieve not only aesthetic harmony, but also functional stability. This approach ensures that corrections are precise, resulting in outcomes that are both natural and well balanced. This structured approach eliminates guesswork, providing a consistent and scientifically validated framework of planning the procedure with precision and confidence. To illustrate this method, let's look at a few more examples. In this case, a patient presented with a medial canthus positioned too close to the corneal edge, creating a disproportionate appearance. By applying the golden ratio, we calculated the ideal position and adjusted the tissue accordingly, achieving a natural and balanced look. And in this patient, she had rounded medial canthus and is positioned too close to the corneal edge. Using the golden ratio, we determine the corrections of each side, restoring symmetry and enhance the overall aesthetic. Here are 3 more examples of how this method can be applied. The preoperative measurements showed a disproportionate medial canthus to corneal ratio. Each of these cases illustrates how incorporating the golden ratio ensures precise corrections that enhance aesthetics, result in outcomes that are natural, more harmonious, and increase the attractiveness of these patients. In conclusion, the golden ratio offers a precise and scientifically grounded framework for epicanthoplasty. By combining this timeless principle with modern surgical techniques, we can achieve results that are natural, harmonious, and functional. Looking forward, this approach could be further refined with advanced technologies like artificial intelligence and 3D imaging, opening new possibilities for standardizing and improving surgical outcomes. Thank you for joining me today. I invite you to explore this new approach further and see how the golden ratio can enhance epicanthoplasty surgery. Together, let's continue to bridge the gap between art and science in the world of aesthetics. If you have any questions, feel free to contact me, and I'm here to answer your questions. All right, thank you.
Thank you so much, Alice. That was wonderful. Any questions from any of the panelists? Rolika, you can check if there is any audience question. If none,
Yes,
then I
ma'am.
have one.
Questions. We'll proceed with your question first.
So Alice, wonderful concept, and we can really see how it just makes the eye look so natural, despite you looking at mathematics while you do that. Have you ever applied this also to cases like blepharophymosis, or sometimes you have a traumatic telecanthus? Does this work there too, or is this only for the so-called East Asian anatomy?
Oh, I'm sorry, I think there are a lot of fireworks at the background.
Okay,
Okay.
the Chinese New Year.
Yes. Okay, now, first of all, because my practice is essentially concentrated in mostly cosmetic practice, so
Right.
I don't usually see a lot of blepharophymosis cases and also traumatic cases. But I suppose, the principles are quite similar. I think it's all about proportion, right? So even if, if you want to correct any epicanthal in phimosis syndrome, blepharophymosis syndrome, you can also measure. But I think maybe for blepharophymosis syndrome, maybe sometimes we may want to overcorrect a little bit because,
Okay.
in this sort of situation, sometimes the scar tissue actually retracts when it recovers. So if you really want to lengthen the blepharophymosis syndrome, you may want to overcorrect. Yeah,
Right.
the medial canthus. Yeah.
There's
you-
one question. Yes, sir. Yes, Dr. Kasturi.
Do you have the same calculation for all types of epicanthoplasty, or you have a different calculation? Supposing it's a Z-plasty or it's a YV-plasty, is it same or different for different types of epicanthoplasty as related to the condition, like is it aesthetic or functional?
I think it's regardless the technique. I think the whole concept of measuring this is just to show you the amount of distance, the amount of correction that needs to be done. So you can do the root Z epicanthoplasty or you can do a redraping method. I think it doesn't really matter. Yeah, it's just to measure the precision in how much of correction to be done. Yeah.
Thank you. There's one question, Dr. Alice, from the audience, and that is that what are the surgical nuances that you keep in mind when the revision patients present to you for epicanthoplasty?
Revision epicanthoplasty, I think depends on what is the issue. Most of the time in my practice, because I'm a bit conservative, most of my epicanthoplasty cases are sometimes undercorrected. So I have patients who come and say, you know what, you have done the procedure, but somehow I just feel that, I wanted a bit more. So I will load the patient's picture again, and I use the rectangle and I will measure and say, oh yeah, you're right. You know, there's still a little bit more to be corrected. So then I'll go ahead and do some correction. Now the issue is sometimes when you do overcorrect, the overcorrection of in epicanthoplasty is a bit more tricky. So depending if too much skin has been removed, it's always very difficult to redrape. So in my practice, I actually prefer to undercorrect, because if you undercorrect, you can always go in and remove a bit more. But once you've overcorrected, it's just a little bit more tricky. Yeah, I hope
Right.
that answers the question.
I believe you're right. Absolutely. Dr. Milind, any more discussion, or would you like us to proceed with the next one? Yes.
Just a comment for Alice. So have you ever held that proportion ratio reverse and checked what's happening with the lateral canthus? And when you align it with the lateral canthus, does it fall short when you come back to the medial?
Interestingly, actually, I have, but the problem with the lateral canthus is that there is no structure to, because right now, you have the cornea to the
Right.
medial canthus, but on the lateral, somehow, it doesn't fall into that that framework. Actually, I tried in many other areas, like the brow to the lid position and a lot of other stuff. But somehow
Right.
in epicanthoplasty, it shows very consistent result. So that's why I applied this mainly to the medial canthus.
So this lateral versus medial, the 3:2 scleral ratio that we've all been taught as residents, does that hold true, or do you think that isn't right?
I've not really paid attention to the lateral canthus. Maybe I should go and do some measurement and see, then I'll get back to you.
Okay.
But I have done, the brow to the lid position, even the height of the crease to the lid, to the opening of the lid. Somehow the calculation just doesn't match. So, but it was very, very consistent with the medial canthus. That's why
Medial.
that's very
Okay.
interesting. Yeah.
Thank
But good
you.
suggestion. I will go and look for it.
Yeah. Thank you, Dr. Allison. Thank you to the panelists for the discussion. Our next talk is by Dr. Stephanie Young Ming on the topic of Asian upper eyelid blepharoplasty. Over to you, Dr. Stephanie.
Can you see my slides?
Yes, Dr. Stephanie.
All right. Okay. So thank you again, Dr. Millen, Dr. Kasturi, organizing committee for this great opportunity to be here. My topic today is on Asian upper eyelid blepharoplasty. These are my disclosures. So Asian blepharoplasty refers to surgery to create a double eyelid in Asians with an absent eyelid crease. But as you know, my dear colleague Alice has published this just in PRS, and I think we just want to be more cognizant about the various ethnicities and variation even within Asia. So perhaps a more accurate way would be to term this, East Asian upper eyelid blepharoplasty moving forwards. So the layman term would be double eyelid surgery. It is one of the most, if not most popular, cosmetic procedure in East Asia. There's a steady increase because of growing acceptance in Asian populations. So moving to the history, the first double eyelid surgery was really performed by Mikamo, Japan's father of cosmetic surgery, way back in 1896. He did it on a Japanese woman who did not have a crease in one of her upper eyelids, so as to address lid asymmetry. And he made clear his intentions were not to westernize her, but to emulate the common unique Japanese aesthetic characterized by double eyelid or futei mubuta. Unfortunately, I think double eyelid surgery had a bad name. It became very popularized in Korea during the Korean War, where a lot of it was done on the on war brides. And even, in recent years, people who undergo double eyelid surgery, sometimes there's a little bit of controversy in it. And this is Tara Banks, firing an Asian woman for accusing her of not accepting her ethnicity. So I do believe there's many reasons why patients want to go double eyelid surgery. And for all of us oculoplastic surgeons who see patients who request for East Asian blepharoplasty, I think we have to keep an open mind. There are many reasons. It could be that they want more beautiful eyes. Sorry about that. It could also be they feel their eyelid creases are asymmetrical. They find it hard to apply makeup. Those of you with monolids will know. And some say, my lids look droopy, makes me look sleepy and angry. I want bigger, brighter eyes. My crease is too faint. So really do keep an open mind. So the aim of Asian blepharoplasty, whatever the reason, is to permanently anchor the dermis to the tarsus or the levator. And it can be achieved through various techniques, each having its pros and cons. We'll talk about the anterior lid approach. It could be closed or open. And we talk about suture blepharoplasty, mini incision blepharoplasty, and incisional blepharoplasty. So everyone's practice differs, but since I'm just sharing with you my practice, suture blepharoplasty actually composes a very small component of my patients undergoing Asian blepharoplasty. And the reason is you have to find the right candidate. So it's best suited for thin eyelids that are not puffy or fatty. Patients who do not mind that they may lose this fold in a few years. It's variable. Some may lose it as soon as a few months even, especially if they have puffy lids, because it's really a suture holding that crease. And of course, many young patients who want to minimize scarring, swelling, and downtime. Usually these are patients in their late teens to their 30s. So there are advantages. It's easy to perform, minimally invasive, faster post-op recovery with less downtime, easier revision. The limitations being fading of the lid fold and a thick eyelid. So if you go into the literature, there are so many ways to do suture blepharoplasty. There's your DST, your continuous and interrupted, and so on. This is just showing the DST, which is quite popular among plastic surgeons in Singapore. So basically you make 3-step incisions, and then I use a Westcott's to sort of deepen these small incisions to create a suborbicularis pocket. And I think why oculoplastic surgeons don't like this is really because we are passing a partial thickness 7-0 suture through the tarsus, and then we are passing it through that hole into the central step suture, and then through the conch into the skin through the medial step suture. This is repeated with another double arm 7-0 nylon or Athlon through the tarsus, the superior border, and then pass through the lateral and central. And this is where you twist centrally, and then you pass that suture back to the lateral step incision. You tie a knot there. And then this knot is buried in that suborbicularis pocket that we've created. Similarly, medially, you pass the double arm, the needle into the medial pocket, and you tie a knot. So that's why it's called DST, because the double twist and turn. And you don't have to close the skin, but I usually do, because these are really just step incisions. It's a really quick procedure, and that's why it's so popular among plastic surgeons. You can see that post-op recovery is pretty fast, to address eyelid asymmetries. And after a month, they heal very naturally. And for patients who want a very natural crease, this works well for them. But I think moving away from suture blepharoplasty, I do feel that mini incision blepharoplasty would suit many more patients and probably be a better procedure. I think it can suit patients even with prominent or fatty puffy lids, which are many of our East Asian patients, patients with lash ptosis or upper epiblepharon. We see many patients who had suture blepharoplasties done by plastics and then coming to us because that double eyelid has faded. Or, even patients who want to minimize scarring and swelling and don't want a full incision, mini incision does really well for them, and it can target a whole age group. We've published this in facial plastic surgery, and this is just a short video showing. So depending on your patient's discussion on where you want the crease to be, here it's 10 mm, so it's quite a high crease because patient wanted a higher crease, and then you just give local anesthesia into these 3-step incisions again, medial, central, and lateral. Medially, I usually lower that incision by about 1 mm. So the great thing about this procedure, if you see there's no bipolar needed, no monopolar needed, I usually just use the handheld cautery. And then again, we make a pocket, the suborbicularis pockets. These are pre-tarsal tissue that we're excising here. This is to allow us to get a good bite of that tarsus later, which I'll talk about. You also at the same time can remove a little bit of fat, pre-or fat here. You can see through these pockets, we're just debulking the tissue. It's a handheld cautery. So this is the lateral pocket. We're debulking some pre-tarsal tissue here. And then we use a cotton bud to sort of support. And this is a partial thickness, 7-0 F1, but it's much smaller needle through the tarsus, and then catching the aponeurosis, and then catching the orbicularis. So I call this the tau suture because it's tarsus aponeurosis orbicularis. And I feel that it gives a very firm, long-lasting support to the lid crease. It doesn't give that static crease that I think a lot of people are afraid of. In fact, it's quite dynamic. And with time, this crease actually is barely perceptible. This scar is barely perceptible, and that crease is not too static. Again, this is the tarsus aponeurosis orbicularis suture. You do 3 of it in the medial, central, and lateral incisions, and just repeat it on the other side. You can ask the patient to open the eyes to check. And again, you don't really have to close the skin, but I usually do with interrupted skin sutures. Okay, so you can see even in puffy lid patients, you can achieve a natural result, and this is at 1 week post-op. These are many patients who've come with multiple suture blepharoplasties. They do want something a bit more prominent, but yet don't want a full incision. You can offer a mini incision, and you do get quite nice natural results even at post-op week 1. So moving on to full incision blepharoplasty, I think as oculoplastic surgeons, this is a blepharoplasty that we need to master. It allows you to address excess skin, the dermatochalasis, suitable for all types of patients, prominent fatty puffy lids, lash ptosis, upper epiblastoma, patients with ptosis, which actually so many patients do have, and of course, revision cases or patients who really want to open their palpable aperture. You may need to placate their levator. So it's suitable for any age group. I really like it in the older age groups. So I think anyone can do a blepharoplasty. It's really skin incision, skin marking, skin incision, excision, closure. But I think to do a good blepharoplasty, you have to think about fat debulking, whether you want to debulk the medial fat pad, sculpt the central fat, lid crease formation, especially important in Asians. And of course, if the patient does have some underlying ptosis or you want to open that palpable aperture, you may need to think of a levator plication or tightening. And I'd like to, really give, I think it was Dr. Wong Chul Choi who taught us about this burden eyelid in many of our East Asians that we have to address with the surgery. So this is just a very short video showing how the marking of the creases. Again, this depends on your discussion with the patient, whether they want a natural crease, high crease, or low crease. And then local anesthesia, skin incision, skin excision. Bipolar hemostasis is important. I like to debulk some of the lateral part to reduce the dot here, debulk a little bit of pretarsal orbicularis. Be careful when opening the septum. I do like to open up septum because I do like to sculpt the fat, and I do like to sculpt the medial fat pad especially, and sometimes do that fat transposition, especially if they have a hollow sulcus. And this I think is an important part. Don't just close the skin, create the crease. This is aponeurosis orbicularis closure. Sometimes if you want a firmer crease, you may need to do that tau suture, which is tarsus aponeurosis orbicularis. And I think you can get quite natural results in patients with excess skin or more severe hooding, patients who had previous surgery, like in this case, she had congenital ptosis on her right eye. Now she wants a higher crease on both eyes. You do need a full incision blepharoplasty to give her the results that she wants. Patients with severe lash ptosis, again, I think it'd be hard to achieve this with mini incision or suture, and that's where a full incision can give a nice result and the lash eversion that you want. Patients with underlying ptosis, if they come in for Asian blepharoplasty, you do need to tighten their levator. It works well even for men. It gives a nice result. And in this case, we also tighten his levator muscle. A lot of cosmetic patients, they already look good, but they want to change their crease, want to change their lid height. Then you do need to do a full incision to really give that finesse to the results that the patient wants. And really, if patients want to open their palpable aperture, you do need the full incision to placate and advance their levator. So in summary, I think East Asian blepharoplasty is one of the most popular and common facial aesthetic surgeries in many Asian countries. We do need to understand the why, but keep an open mind, especially if you're doing lots of it. Suture, mini incision, full incision techniques have their pros and cons. Know what type of surgery works in your hands. Everyone is different. Every surgeon is different. And do select an appropriate technique for the individual patient. So thank you, and do save the date for our APSOPRS Oculofacial Aesthetic Masterclass, 19th and 20th July. Thank you.
That was really a very nice presentation, Stephanie. I just want to know, like from you, in case of mini bleph, do you think that sometimes it fades off faster than the total excision blepharoplasty that we do?
Actually, not really. I think if you select the patients well, that mini bleph, if you see, will actually, I mean, at least I like to placate to the tarsal, so that gives a really firm crease. And I feel that the rate of the crease fading is actually lower than in the full incision bleph where you don't create a firm crease.
And I think there's a difference of your crease formation from Dr. Ellis. Dr. Ellis, you take orbicularis, LPS orbicularis, right? And you
Yes.
take
I
and
take
Yes.
aponeurosis orbicularis. Yeah, it's different. I think, like I said, everyone has their preferred technique. What works well on Alice's hand may not work well on my hand. So I feel that the tarsus, I feel that tarsus catch is quite important.
So do you
Actually-
take only tarsus, LPS, and orbicularis, or you take orbicularis, tarsus, LPS, orbicularis?
No, I do tarsus, aponeurosis orbicularis.
And Alice?
No, I think that, the tarsus suture, if you were to do the full incision and if you make too much of a tarsal plication to the tarsus, then there is always a small risk of you having a bit of a depressed scar. That's what I think. So I think the whole idea of plicating it in aponeurosis, you can actually take a good bite at the levator. It's purely because of the dynamic crease. Because I feel that if you were to take a bite, especially if it's a very deep bite to the tarsus, it actually causes a bit of a static because of the adhesion to the tarsus, which is a rigid structure. That's what I feel. But maybe in Stephanie's hand, even though she had the tau suture, maybe because with the mini incision, because it's a small incision, you only attach to the certain parts of tarsus in a very specific area. So maybe it's not as bad as compared to the full incision, and you actually make a lot of attachments, to the tarsus in many points. So that could essentially cause a depression, I think.
And one more question, at what height of the LPS, aponeurosis, do you place the suture?
I don't measure the height. Usually it's really where the aponeurosis is just above the tarsus.
Above the tarsus. Okay. Anyone else, do you have any other variation? Because I usually measure approximately 4 millimeter, and with the 4 millimeter just above the tarsus, I get a little, enlargement of the palpebral fissure, approximately less than, it's around 0.2 or 0.3 millimeter, and it really gives a very nice show. But anyone
Yes.
else? Yeah.
I'm curious to know what Helen does in this
Yes.
situation.
Thank you for your wonderful lecture, Stephanie.
Thank you.
To the questions from Katsuri, I do not make the point of fixation point of aponeurosis just above the tarsus. I think that's the better point or preferred point for the East Asians. But as you mentioned, a little higher than the tarsus height, I think it can be adjusted for the South Asians. And regarding the suture technique, DTS, I reported a little modified technique, and I called it BTS, buried,
nice.
buried twisted suture technique. It means I did some kind of modification at the center point, not only the twisted sutures, but I made several layers of ties to make the firm pillar at the center of the eyelid, so we can enjoy the benefits of continuous suture technique and interrupted suture technique using that one. And also I can do some remove the fat, orbital fat from the step incisions. Then we can can apply the suture technique even for the late 40s.
Great.
With the patients. So, or you can adjust the height of the fold to adjust the skin fold.
So, Dr.
Yes.
Helen, with your modified BTS technique, do you think that the suture blepharoplasty actually lasts a long time? Because that's the main criticism about suture.
Yes, that's the strong point, the benefit of the modification of the DTS. And finally, BTS. Yes, indeed.
Thanks for sharing.
And also you remove some amount of the pre-tarsal fat, right?
Yes.
Pre-aortic fat.
Yes. Yes.
Okay, thank you everyone for the interesting discussion on the East Asian blephs, as we would like to call it anymore, right? And I invite our next speaker, Dr. Kasturi Bhattacharjee, for the topic Types and Techniques of Lower Lid Blepharoplasty. Over to you, Dr. Kasturi.
My slides are able, can be seen well?
Yes. Yes,
Can you
perfect.
well?
Yes.
Audible well now? Okay. So I'll
Yes.
be speaking on the types and techniques of lower blepharoplasty and no financial disclosure. So I always believe that a lower lid blepharoplasty has been used to address the undesirable changes, the aging changes of the lower lids, wherein the variable amount of the lower eyelid fat pads are being excised, or it is being sculpted or transposed to achieve a more rejuvenated appearance. So all this occurs because of some topographic changes, which can be a soft tissue topographic changes. And these soft tissue topographic changes basically includes the eyelid bags, the malar mounts and festone, and this together forms the double convex deformity. So along with this, the other aging changes we see are the lid laxity and also the tear trough, prominence of the tear trough. Along with the topographic soft tissue changes, we also come across the topographic bony changes, which are differential, uneven, and site-specific bony resorption, wherein we see the resorption occurs more in the maxilla as compared to the zygomatic bone. So a combination of both the topographic soft tissue and the topographic bony changes leads to the development of the negative vector from the positive vector. And because of all these changes, we end up doing multiple surgery around the periocular region in order to give a more rejuvenated lower lid. So when I talk about the types of the lower lid blepharoplasty, it basically includes the transcutaneous, the transconjunctival, the skin excision, and the fat repositioning. And when I talk about the techniques, it can be either an excision technique, sculpting, repositioning, or the skin tightening. But what I want to share here, I want each of you to go through this paper by Fessa et al., who has very nicely shown that corresponding to the lower lid length, which usually lengthens as we age, the surgical treatment he has mentioned, which can be either in the form of fat removal, or after removing the fat, we can augment it with filler or a nanoplasty, or we can go for transconjunctival fat redripping or a pedicle graft. So it is a very easy way to go for only fat removal, because we just need to expose the tree fat bed and you need to excise the all tree fat bed. And it really works very well for the young people who do not have a double convex deformity. So this is very wonderful and a fast surgery, giving a very nice effacement of the lid cheek junction that we see, which really overcomes the lower lid bags. But what we see in the Indian population, after the excision of the fat, we come across pigmentation and we see loss of periocular hollowing. So these are the patients where we need to augment this periocular hollowing either with filler or with a fat graft. And this not only decreases the shadowing effect, but also fills up the hollows. And we get a much defined look following this augmentation with a filling agent. So this is how they look, the pre-op, and this is the post-blep with so much of pigmentation, and this is immediate after the filler injection. And not only the shadowing effect gets decreased, but also you see the periocular hollowing is much less before and after this procedure. And with all the different procedures being done, the bleph and the filler, and the cheek filler and the periocular fillers, they look much more rejuvenated, not only in the periocular region, but also the whole of the face. Sometimes what happens in elderly people, we also do plan only a fat excision, but we need to take care of the entire lamella, because only fat excision may not give a very rejuvenated lower lid, because the skin is much wrinkled because of the aging changes. So here, after doing a transconjunctival blepharoplasty, we need to excise some of the skin. But the thumb rule when we deal with the lower lid, it should be any procedure, whether it's an entropion, whether it's an ectropion, or any skin excision, it is always under correction. And upper lid, we should go for always over correction. So what I do, once I finish the transconjunctival approach, then I come and excise the skin, doing a small pinch test, and then you suture it with a monofilament, either with a PDS or with a Prolene suture. But what I prefer, and I have been doing for the last almost a decade now, is the tissue preserving fat redripping, where I take the orbital fat, I fashion the orbital fat in the form of the pedicle, transpose them as down as possible in order to restore the apparent volume loss associated with facial aging. So the most important step, you need to release this osteocutaneous ligament, that is orbitomallear ligament, and once you release this orbital fat, you create in the form of a pedicle and transpose them as down as the lower level of the nasal NLF. This is a very interesting paper where they have shown that after the fat transposition, if you can make a very good pedicle, the volume and also the vascularity of the fat pedicle is also seen 8 months following this surgical procedure. You can have the pedicle in the form of only one pedicle, the medial, or you can have the medial and the central, or medial, central, lateral, and you get a very good result. This is the second post of day, and you can see the very good effacement. The bulge has gone out, and this is not showing any hollowing because his fat bag was much less and it was not showing a double convex deformity. So you can, depending upon the condition, you need to fashion the pedicle, and it really gives a very good result. And the results I have seen, it really lasts for more than 5 years. Almost some patient I'm following for the last 10 years, giving a very having the same beautiful result as we have done in the early days. So what I believe is, we know that by anatomy, we have got the 3 fat pads in the lower lid. There is an inferior oblique muscle between the medial and the central, and an arc expansion between the central and the lateral. And when we look to the anatomy, this middle fat pad is much anterior as compared to the medial and the lateral fat pad. So depending upon this anatomy, we need to really dissect deeper for the medial and the lateral. I do not like to cut the whole of the orbital septum, but I just want to making small openings, because this orbital septum, too much of manipulation can lead a middle layer cicatrization, which we see in some cases as a complication of lower lid blepharoplasty. So a 3-step incisions are being given in the orbital septum, and then once the fat pedicles bulges out, the fat is being, I just tease the fat out. But the most important step, that you need to separate the medial from the central fat pad very well, separate all the adhesion, and then you create the 3 fat pedicles. The creation of the fat pedicle is very important, using very less amount of cautery. You can see this is the inferior oblique muscle, and this fat pedicles, we use less amount of cautery so that the vascularity is being maintained. And then you need to, before you transpose, you need to release the orbitomallear ligament. This orbitomallear ligament is a true ligament. That means it is an osteocutaneous coming from the bone and inserting into the skin. So a very liberal dissection should be done in order to release. I go a pre-periosteal, in fact, I should say a suborbicularis in all my cases, and then you transpose this orbital fat as down as possible, and this will give a very good effacement of this lid sheath junction. So this is how we create the 3 fat pedicle, and the tip to is that you do not use much cautery. Try to do a deeper dissection into medial and the lateral fat pedicles so that you get the long fat pedicles, and then transpose it using a monofilament. Either it can be in the form of a proline suture, or I prefer using a 5-4 PDS. Advantage of using a PDS is a transparent, so post-operatively it doesn't, the blue color is not seen, which we usually see with the proline suture. And also I have seen many cases of proline reaction, which very soon I'll be reporting. I have seen around 6-7 cases of proline reaction. So that is what, this is how we end up the surgery. And if you really see, it really gives a very good effacement of the lid cheek junction, even the morph out here. You can see it looks very nice. But the most important thing, that it converts this negative vector into a positive vector following this procedure. And a very beautiful effacement we see. And as Dr. Goldberg has already taught us, that if there is a lateral canthal laxity, we usually go for lateral canthal tightening by going a suture through the lid margin. And this is something like a plication suture that we do it from the upper lid. And this really tightens the lower lid, and we get a very good correction. But important points to remember, whether we do a transconjunctival or a transcutaneous, these 3 points should be always kept in mind while doing the surgery. Number 1, the critical zone. Number 2, the recess where Eisner. And number 3, the auxiliary fat, which we also call the pre-tarsal fat, which we see in Northeast India or in the Asian community. One important aspect I would like to highlight, the effect of the gravitational force, which plays a very important role in the morphogenesis of the midface. In this paper, Manley et al. Has shown that while in the sitting position, because of the effect of gravity, there's deflation, there's deterioration, there's descent, the aging changes much there. And when the same patient in the 3D picture, you see when they lie down, the effect of aging is not seen. That means we need to work something against the gravity. And the best way of working against the gravity is you need to manipulate the mass, and you need to do something like a little bit of mid-facelift. This mid-facelift can be done both through a transconjunctival approach or a transcutaneous approach. When I do a transcutaneous approach, I usually remove the lateral fat bed, and rest of the surgical procedure is same, where you fashion the medial and the central fat pedicle, suture it as down as possible, usually the suborbicularis, and then you try to separate the mass from the overlying structures and try to lift the mass. And the advantage of this in the transcutaneous is that along with all this mass lift, you can also do some amount of lateral canthopexy or canthoplasty, giving a good effacement of the lid cheek junction. So this is what I was doing in my initial days. But now what I do in most of my case is that I try to expose the mass in a much, bigger area. Like in this lady, you see, this is just on the table. This side, you can see lower lip blepharoplasty and then the mid facelift, and this has not been done. And you can still see the nasolabial fold being much prominent. And this is on the table after the correction, where you can see a very good lower lip blepharoplasty along with the mid facelift. So this is a surgery of the same lady I'm showing. You just look, see, this is how much this whole NLF is so prominent because this side is much lifted. So as I shown how we do a low lip blepharoplasty by transconjunctival approaches in exposing the inferior oblique, then you complete all the flap, and then you do a skin pinch and expose the skin. And now what I use the same instrument which I use for this is the trapezium instrument, where you can separate very well from the skin, the mass from the underlying skin, and try to separate as much as possible, expose the superficial temporal fascia, try to pull the whole of the midface and suture with either a 2O vicryl. I prefer using a 3 sutures or 2O vicryl. The main concept of either a mid-facelift or facelift that you need to release the ligaments and you need to change the vector. You do not need to excise much of the tissue. So you can see on the table, this one NLF has been corrected. So this is the beauty of doing a low lip blepharoplasty along with doing a mid-facelift. So this is how the patient changes from this to this appearance. But the low lip blepharoplasty has got multiple complications. So one should do a very meticulous and a very careful surgery. These are some of the major complications, but what is the worst is sometimes there can be bleeding leading to orbital hematoma and a loss of vision. Thus, to conclude, the lower lip blepharoplasty is a transformative procedure that addresses the aesthetic concerns of the lower lid. So we need to select the appropriate types, the appropriate technique. But the most important aspect that we should have a very clear understanding of the anatomy and also the concept of aging. Thank you very much for your patient hearing. Hope I was audible well during the
Yes,
presentation.
very, very well.
And the videos were playing
Yeah.
because
They were perfect.
Absolutely. So, Yvette, do you have any comments or questions, since the Filipino anatomy could be similar to the Indian ones?
Well, yes, but well, I would like to brag that we age slower. Maybe because so most of my patients are in the much older age group when I have to do extensive lower lid blepharoplasty. But just a comment, I've actually, Dr. Kasturi, the redraping of the 3 fat pads, I've seen your presentations about it, but I find it challenging to get the lateral fat pad. How do you make it look so easy to access the lateral fat pad through a transconjunctival incision? Do you extend it or do you dissect it? Do you have tips on how to do that?
Yeah, the lateral fat bed is much deeper as compared to the central fat bed. So what you do, I usually pull the conch superiorly, and you ask the patient if it is under local anesthesia, then you ask the patient to look up, and then you start dissecting in the lateral plane. Dissect in 2 directions. One is definitely vertically down, and also one is horizontally. Why horizontally? I'll tell you later. Vertically down, and then you give a little pressure on the eyeball. You'll see the lateral fat pad popping out. Then immediately you hold it and start dissecting. That is point one. Point two, horizontal, that is the recess of Eisner. I have seen that many bleph being done outside, and the later the patient comes to me with a small swelling here. And this is the spillover fat. If it is not being taken care, but later it will not come immediately after 3 years, 4 years. This spillover fat comes more superficial in the recess of the racers. So even need to do a little bit of horizontal dissection to see if there is any spillover of the fat during the surgical procedure. Is it clear?
And well, the reason why I'm scared to dissect so much on the sides, I've had patients who develop festoons with extensive dissection laterally. So what are your landmarks how to avoid destroying the lymphatic system in that area?
It's a very good question. If you do smash lift, you will never get a festoon. Never get a festoon. So basically we should not keep any hollowing out here. So the moment there are two ways of doing a mid face. Many people do this and many people do this. This I don't like much. Initially I used to do, what happens? We lift the face laterally and the face looks very widened. But if you lift this vertical lifting, we lift this apple of the face and the face doesn't widen. In the meantime, you're also lifting this mass. So a small, same incision, I do not go much lateral to this lateral canthus. My maximum lateral end will be in the orbital rim. I just sometimes draw like this, never cross this orbital rim. Take a 3-prong and retractive, and you'll see the temporoparietal fascia very well, the superficial temporalis fascia. So this can really help you to change the vector of the smash. Okay, so from here, you dissect the smash. You can use the same that olive tip instrument I'm using. If you don't have the olive tip instrument, what you can use, the nasal speculum we have, no, the long nasal speculum, that is also a good separator. You can separate with that the whole of the smash, lift the smash, expose the superficial temporal fascia, and then you lift it in a vertical direction. So this will overcome all this, the loose space here, and the festoon will never, I have never seen any festoon in any of my patients.
Thank you.
Thank you, Dr. Kasturi. Yeah.
Not necessarily the lateral fat pad should be, many of the I excise the lateral, I transpose the medial and the central.
Thank you, Dr. Kasturi. Yes, Dr. Alice, please go ahead.
Yeah, thank you, Kasturi, for such a wonderful presentation. Now, the question is, most of us would want to, when we do a transconjunctival bleph, that's because we want to avoid any, incision on the skin. But if you combine with a mid-facelift, then you cut through the skin, you are essentially creating the skin, a scar. Is it possible to do the mid-facelift transconjunctivally instead?
I tried doing transconjunctivally, but what happened in this smash is very superficial. That is, the orbicularis is also considered a part of the smash. How the smash comes from the cervical fascia, platysma, smash, orbicularis goes up to the galea. That is a very superficial layer. So when I do transconj, I feel that I'm not being able to hold the smash well. So I do this mid-face lift only for elderly patient, and only pinch the skin and remove the skin. But the whole surgery I do transconj in order to prevent the adhesions and other lid retractions. So if I go to, I feel the separation is easier in my hand.
Thank you, Dr. Kasturi, for sharing your experience. And yes.
Edema, I don't know, is more when I do transconj mid-face. Then when I do transcutaneous, I don't get any lymphedema. In fact, the patient looks really nice the next day. But when I do through the transconj, for some reason, I don't know. I think I got more of the lymphatics or what, I don't know, but I do get more swelling. Sorry.
No, that's okay. Now
Sorry,
I invite.
Sorry. Do we have time?
Yeah,
We
go ahead,
actually,
Dallas.
yes, go ahead.
No, sorry. The other question is, how about chemosis? Do you often get chemosis?
Not chemosis. I don't mean to, but quite late edema, but routinely I give 0.5 decadron injection And that has really decreased steroid injection. That has really decreased my post-op edema, both for the upper lid bleph and also mid face, lower lid, everything. So I give at least, I take 4 milligram we get, sorry, 4 for 8 milligrams. So 4 milligram on both the side. If it is both upper and the lower, then 2, 2. And if it is only lower, the full 4 milligram here and 4 milligram the other side. And this has really decreased the post-op edema. And it really has brought a big change in my practice.
Sorry, where do you inject again? You inject into your incision area, or where exactly which plane do you inject it to?
Where I feel that the effect of gravity will be more, the fluid collects, especially in those areas where the ligaments were initially there. Now to be released the ligaments, right? So any point, we don't know how much ligament we have released. So the points of the ligament, the orbitomallar ligament, the zygomatic ligament, and sometimes in the facelift when we also do in the masseter ligament. So these are the 3 points that I inject the steroid.
Okay. Thank you.
Thank you, everyone. I now request Dr. Milind Nayak to speak on aesthetic considerations beyond blepharoplasty.
Yeah, thanks, Rolika. Thank you, everyone. Thank you, AIOS, for this opportunity. So I work at the LV Prasad Eye Institute that's in Hyderabad, the southern part of the country. And it's an honor to be a part of this APSOPRS AIOS webinar.
Milind,
So
1 minute. I should introduce you. No one introduced you. So let me just say 2 lines about Milind. Milind is a great academician, a great YouTuber having more than 30,000 subscribers. Is a hats off to you. He is the present Vice President of Asia Pacific Society, all of you know APSOPRS, and also a very dynamic secretary of Oculoplastics Association of India. And lots of publication, has got one of the highest number of publications amongst all of us. So that's a very brief introduction. So over to you, Milind.
thank you, Kasturi. So I'll quickly touch upon the adjuncts to blepharoplasty, periocular, a little bit about dermoids, and then orbital surgery. We've heard about the bleph, and we are aware about the skin excision and sometimes the muscle and fat. But there are several components that go into the blepharoplasty surgery, which may not be that obvious to a novice. One of them is brow volumization, brow elevation. Brow elevation can be done by excising a little bit of the temporal orbicularis. So when we do the blepharoplasty, in the outer half or outer third, if we remove the orbicularis, that gives the frontalis a slightly upper hand, and it ends up raising the eyebrow to a certain extent, at least theoretically. Well, you can also combine a blepharoplasty with an endoscopic brow lift, and that's an obvious correction of brow along with bleph. And here are examples of the same. Here is a man in whom we did what is called as a pretracheal or a hairline brow lift, as you can see for his right brow, which was just an asymmetry of his face. And in addition to that, the brow volume augmentation is an option. You can either do that as a fat transfer, which is done right at the time of your blepharoplasty, autologous fat transfer, or you can choose to do fillers later on. But what is important is to fill the deflated brow with volume in the form of filler or fat so that the contours are again regained. We can also combine a ptosis surgery with this, which is in the form of levator reattachment, or more often, it's an MMCR. I prefer to do an MMCR even when I'm doing an upper eyelid bleph, just because of its predictability. The medial fat pad is often missed out, and it's important to remove that when we are doing an upper bleph. Here is a lady where the medial fat pad was specifically one of her concerns. And apart from the skin, I focused on that fat pad so that we could kind of rewind her appearance to what she looked earlier. Prolapsed lacrimal gland can be missed out in patients who have borderline thyroid eye disease or those who have blepharochalasis. And this is something which is to be expected in down gaze. You have to gently press on the eyeball to make it obvious. And then that would require a specific refixation during your during your blepharoplasty surgery. Sometimes the blepharoplasty is just about creating a lid. Stephanie touched upon this topic. Here we don't excise much skin, but we actually create a fold. You can call it a fold creation. Double eyelid surgery, I would not go there. We have covered that very well. Talking about lower eyelid bleph adjuncts, we know that the lateral canthus is slightly higher than the medial, and with age that can descend. So fixing the lateral canthus with a very minimally invasive lateral canthal resuspension, where you start off with your prolene at the orbital rim slightly higher than the medial canthal position. Then you come out through the suborbicularis plane, exit it through the last meibomian orifice, go back through the same opening, and then come out through the periosteum so that when you stretch it, your canthus actually moves up. So here's an example of the same being done along with a simple ptosis surgery and a minimal blepharoplasty. And skin pinch, Kasturi already showed it, so I'm just going to skip in the interest of time. In patients where you have lid cheek junction, which can require volume addition, instead of doing mid-face lips, which don't work well in my hands, I prefer to add fat in that area to just blur that lid cheek junction, apart from just doing a blepharoplasty. So here's an example of a patient with lower eyelid bleph and a hollow, where we treated her with, a fat bag and a hollow, where we treated her with bleph and microfat injections. Here's another example. Here, this is a clear-cut indication of repositioning, which unfortunately doesn't work well with me. So I prefer to just do the bleph and fill it with autologous fat transfer. A little bit about functional and aesthetic dermoids. When they can be removed through a lid crease, that's great, but sometimes they are fixed to the bone, in which case you can still remove them through a smaller incision by actually opening up the dermoid, collapsing it, aspirating the contents, and then delivering it out through a smaller incision, very similar to how a cataract surgery is done. Pretracheal incision also can be great for large dermoids. And sometimes you can even get them out, the frontotemporal ones, through an endoscopic approach. So here's a patient where the classic endoscopic brow lift incisions were placed to get in and remove a frontotemporal dermoid. You have two layers to dissect. One is above the dermoid and the other one is below it. And then the dermoid is gently expressed out through one of the incisions. So another option which could be available here is a direct incision onto it, but that scar is likely to be visible. So here's the patient a couple of weeks after the surgery. You can see the collapsed frontotemporal dermoid. You can also do sclerotherapy for these patients, and that's a very good option when patients present really late in life and there's no way to get the dermoid out without a visible incision. Talking about orbital surgery, we all are aware of orbital decompressions, which are mostly done for cosmetic reasons. For patients who have inactive thyroid eye disease, we have 3 walls to choose from. And these are all examples of patients who have undergone either 2 or 3 wall decompression, sometimes in a customized manner, like in this lady, where we preferentially choose the floor to reduce the inferior scleral shrink. Here's a unilateral thyroid eye disease, which underwent a mulerectomy and orbital decompression. We also combined eyelid surgeries with decompression. For example, here, levator reattachment was combined with a fat decompression. And you can also apply this to non-thyroid causes like myopia. Thank you so much.
Thank you,
Wonderful
Dr. Mehmood. Yes, Dr. Kasturi, over to you.
wonderful presentations. Like how to titrate, especially when you go for a cosmetic decompression in a thyroid eye disease, whether you'll go for fat decompression or fat and bone decompression?
Well, I discuss it with the patient. Many times the disease is entirely unilateral and the planning is simple. Sometimes it's bilateral or symmetric, and then I have to talk to them whether we are operating on both eyes or just the worse eye and matching it to the better eye. So finally, after that discussion, I come to know how many millimeters of reduction I need to do. And generally, my decision is based on that. If it is 2 or even 3 millimeters, I could talk to them about just fat decompression, provided it's fat disease. But usually I, plan more number of walls than what might be required. And then I can always cut down on it if needed. So 3 to 4 millimeters of proptosis, I might talk to them about one wall and fat, and then reduce it down to just fat or just one wall. That has been my approach.
And do you do a low-lead blip in such patient of fat decompression?
I think the fat usually settles when you remove that extracornal, inferolateral, as well as a little bit of intracornal. So on table, I do assess whether their initial fat back complaint has collapsed, and it usually does. So I don't mentally think about it as a bleph. I just go deeper into the orbit, remove the fat, and that works out as a blepharoplasty in itself.
Thank you.
I have a question, Dr. Nayak. Like in cases where you have a bony attachment in the orbital dermoids, so
Yeah.
would you still proceed with, in the same location as you showed in the endoscopic view, would you still proceed with endoscopy or would you convert it to open? Like, are you comfortable taking the bony, adhesion out by endoscopy?
Yeah, I mean, I've not done too many of these endoscopic approaches. That was one patient where she was really not okay with an incision, not even with a pretracheal. So we just tried it out. I mean, in any such case, I would tell them that if I'm not able to dissect it out well, I will have to go ahead with something. I'll have to have a fallback plan. But I'm okay to even rupture the dermoid during the process, collapse it, and bring it out if required. So my focus with dermoid will be on trying to avoid a visible incision, not trying to get it out intact.
Well, that was a very beautifully done endoscopic approach.
Thank you.
Yeah, Milan,
Yes,
Yeah,
Doctor.
hi.
then it wouldn't be difficult to actually dissect and remove the rest of the capsule or whatever, right?
That was scraped along with the periosteum, Alice. So the lower part of the dermoid came with a circle of periosteum with it. So I had to scrape it in the bone plane.
Thank you. So moving on to the case discussions.
Can I ask one question?
Yes, Dr.
also?
Evan.
Just one
Yes.
question. Hi, Milid. Well, impressive presentation as always. But you mentioned about doing a little bit of brow lift through a blepharoplasty incision. It has
Right.
been presented, and I've tried it actually, that instead of doing a pretarsal incision, they actually do a sub-brow incision to do the blepharoplasty and remove skin from there.
Right.
And essentially that does what you're talking about, and it does a little lift, and people who do believe in brow pecs, you can do that too. Have you ever tried that technique?
No, I mean, unfortunately, I'm always worried about a scar being visible. It's very similar to, let's say, a stellar right incision. And in many of our functional patients, I see that those scars are quite visible in the Indian patient. So I'll have to either wait for the right kind of patient whom I can select for that procedure, or I'll have to watch one of y'all who do it well. I don't have much experience.
Does anyone in the panel do that technique?
I think Steph does.
Yeah.
Yeah.
I do a lot of sub brows, but not to give a brow lift. In fact, sometimes it does pull the brow down. It's really just to address the natural hooding. I think if you want to do a
Okay.
brow lift, you need to do that pretracheal or that direct or the endoscopic. that subbrow will not work.
It's not really to address brow ptosis, but more similar to what we do in Botox, just to remove a little orbicularis for the lift, and not really for a full brow ptosis.
And even the transbleph browpexy, I've done that in the earlier years, and it looks so artificial. Even if you fix it with one suture or two, it doesn't give you that natural look. So I stopped doing that.
Yeah. Yeah, I don't believe in the browpexies.
We'll wait for the talk later.
Thank you, everyone. And moving to the cases, I request Dr. Purnima Stapit to present a case on one size fits all in upper eyelid bleph. Over to you, Dr. Purnima.
Good evening, everyone. Thank you, Dr. Milind and Dr. Kasturi, for the invitation, and thank you, AIOs and APSOPRS, for the opportunity. Are my slides visible?
Yes.
Yes.
First, I would like to advise a bit on the racial variation of upper lid, which we all know. In the Caucasians, the upper eyelid septum is attached at the higher level in the LPS, so that the lid crease is higher in them, whereas in the Orientals, the septum is attached at a very lower level, sometimes just above the tarsus or even below it in front of the tarsus, allowing the preopineurotic fat pad to descend downwards, thus creating a very small or absent lid crease. For example, in this young lady, the dermatochalasis is too severe for the age and the lid crease is not visible at all. But only on the down gaze, you can see the thin and a low set lid crease. This problem is accentuated in the elderly population because they already have a low setting of the lid crease and a lot of fat in the upper lid. And with age, with the redundant skin, they manifest the severe form of dermatochalasis early and also in the severe form. Like in this case, the patient is looking in the primary gaze, but the dermatochalasis is so severe that you can hardly see the cornea and it's obscuring the visual axis. On lifting up the skin, you can see that there's a faint low-sided lid crease and some amount of ptosis and brow ptosis in the left eye as well. So what type of patients account for blepharoplasty in our setting are mainly three types. One is an absent lid crease or asymmetrical lid crease, like in this young lady, who doesn't want a similar lid crease like in the left eye, but she wants a higher lid crease in both the eyes. Another type of patients are with the very beautiful but low set lid crease, but they want to raise the lid crease at the higher level. The third type of patients are elderly with severe dermatochalasis. They are not concerned about the lid crease, but they want to remove the dermatochalasis. But in all these three types of the indications of upper lid blepharoplasty, can we do the same technique? This is not any new technique. It is already shown by Stephanie previously, and also I'm sure most of you are doing the same thing. But I would like to just show that they can be done in all three indications. First, the markings. The center marking we take around 8 to 10 millimeters because the people want a higher lid crease in our setting. And the medial one, I make it 2 millimeter lesser, and the lateral one 1 millimeter lesser than the center one. Then it is obviously slanted upwards to remove an excessive skin. So the lid crease looks, the incision lining looks something like this. So after the local anesthesia and incision along the marked area and removal of the skin and the orbicularis, we do the transection through the orbicularis muscle along the upper incision line and thus opening of the orbital septum and exposing the fat. But we do not usually remove the preapineurotic fat because the patients are used to having the fullness of the upper lid, so we don't want to create a hollow. But it is important to remove this the strip of the excessive tissue, which is made up of tarsal orbicularis, some part of the remaining septum, and some the subcutaneous fat, and also the suborbicularis fat, because it is an important factor in forming the good lid crease. Then we put the sutures in the form of take a suture permanent non-absorbable 7-0 proline from the pretarsal orbicularis and take the bite of the levator wherever the skin crease meets the levator, which was discussed previously also. And then this is in this picture, the center one is already taken and we are going to take the lateral one. So here's the schematic diagram of the lid crease suture being put. Then the skin is closed with 6 so interrupted either bicryl or proline sutures, making sure to bury the crease forming sutures inside. Thus it forms a deep and a higher lid crease. So some of the pictures I would like to show are, this was a blepharoplasty done in a young male who doesn't have a lid crease. I mean, he has a monolid, but he doesn't want the high crease, so we did a 6 millimeter lid crease in both the eyes. The same patient which I had shown earlier, we made a lid crease in the monolid as well as made a symmetrical higher lid in the other eye as well. This lady, obviously, middle-aged lady, came for dermatocalasis. For these patients also, we do a lid crease incision, lid crease suturing, because the pretarsal show is important in the Oriental people, because when the patient ages, this dermatocalasis is going to again increase, and also there will be some component of the brow ptosis. But if we just do the removal of the skin and just direct suturing, the fullness of the upper lid still remains, and with even a little bit of brow ptosis or this excessive redundant skin, the patient is going to have obscuration of visual axis. Hence, we prefer to do a screen crease suturing, even though the patient don't ask for, because so that the pre-aponeurotic fat pad is stopped by this suturing on coming below the towards the cornea, towards the visual axis, and also stops this skin from coming towards the visual axis. So on the table only we can find out then the skin suturing will be deep, showing that there will be a good crease formation later on. Hence, I'd like to conclude by saying that single procedure can address all 3 indications of upper lid blepharoplasty in all age groups, and also for the beginners, for the surgeons, it helps to enhance their skills because they will be doing the same procedure in all their patients. And thank you. These are my references from where I took the diagrams. I would like to thank my colleagues Pranita, Home, and Malita for helping me with the slides. Thank you.
Thank you, Dr. Purnima. And I request Dr. Alice to please lead the discussion.
Rolika, how many minutes do we have?
Ma'am, we have 4 minutes for the cases and 4 minutes for the discussion.
We have another 15 minutes for
We're
the.
lagging by 17 minutes for now.
Then we'll take a one question.
Yes, over to you, Dr. Alice.
Alice, you're muted.
We can't hear you actually. You are unmuted, but your audio is not there.
Admin,
May I
can
request
we?
May I request Dr. Stephanie to take the discussion instead? I'll just check with Dr. Alice.
Yeah, thanks, Purnima, for discussing. Blepharoplasty is always challenging. I mean, it looks simple, but like you mentioned, even within your population, Nepal, there's so many different types of blepharoplasty. So I may have missed it, but in your blepharoplasty, how do you form the crease for all your patients? I think I didn't catch that part.
One point is to open up the septum and
Mhm.
expose the levator and the fat. And second point is removing a strip of a tissue which composed the tarsal and in front of the tarsus, the tissue composed of the remaining orbicularis and the subcutaneous fat and the remnant of the septum, those things. It also to decrease, to form an empty space between skin and the levator. And then taking a bite from the pretarsal orbicularis and then a bite of the levator.
I see.
Wherever
Okay.
the skin rests, the lower
Alright.
edge of the skin rests.
Okay, thank you. I just want to clarify. So it also sounds like you don't catch the tarsus, right? In forming your
No.
crease.
Oh yes,
Okay.
we don't.
Great. Thank you, everyone. And we will move to our next case in the interest of time. That will be by Dr. George Cheng, and it will be on cosmetic ptosis correction. Dr. Alice will just join us back again.
Thank you, everyone. Let me to join this presentation. Okay, my topic is the cosmetic ptosis correction. And then can you see my slide?
Yes.
Yes, we can.
For a good ptosis correction, it just means we need to get a good height correction and also the lid crease and also eyelash. Therefore, my techniques is posterior approach, conjunctival white line advancement with 3/4 silk sutures. This is my case to share with you. And then this is the patient for the left eye ptosis correction. And then I want to show you the anatomy. Before the surgery, you should know where is the levator. In this case, 13 mm from the eyelid margin. Therefore, it's not for you and me, but for the beginners, you have a good knowledge where is the levator. And in this case, I do the 8.5, and then we mark the skin incision, and then we do a traction suture. Doing all type of eyelid surgery, ptosis surgery, the traction of the skin tissue can help you a lot in the operation. Therefore, this is 8.5 mm. And then therefore we do a conjunctival incision. This is, I just marked the point, it's 13 mm, showing you the where is about the point, you will find the levator muscles, okay? Therefore, we do is conjunctival incisions, and then through the lateral incision and the medial incision, and then with a good traction with the desma retractors, you will track the levator muscle very good. Therefore, with just cotton wool sticks, you can dissect down to the levator muscles. And then if you measure, it's around the place where we pre-measure, and you'll find the levator muscle. In case you're not familiar or anatomy, or in some complicated cases, you will always find the levator muscle. Therefore, now we just put a 4/0 silk suture through the skin. And then before that, we need to track the skin, make sure the eyelash, the skin is in good tension. Therefore, we pass the sutures, and then we will have a good bite. There are three choices. You can the anterior surface, at the edge, or the posterior surface. In this case, the patient have a good levator function. Therefore, we just put a good bite in the center of the anterior surface is good enough. Therefore, for the first bite, you transfer the levator muscle force to the skin and to the eyelid. Therefore, it will correct the height of the ptosis. Therefore, the first temporary suture, we will adjust the height, make sure it's in good position. And then for the medial sutures, they help you to adjust the contour of the eyelid. Therefore, if the height is good enough, you just take a bite of the levators and then through the skin. And then with two sutures, usually it will support the eyelid in good positions. Both the height and in contour is to give you a very good positions. And then after these two bites, we need to tie the notch and then assess the patient eyelid conditions. And then after tying these two stitches, you see the contour and also the height of the eyelid is in good position. But now you need to look at the eyelashes. You see the eyelashes at the lateral side still have some lash ptosis. Therefore, the lateral bite, the third 4 silk, we want to correct the eyelash ptosis. Therefore, in this case, we don't want to change the height or the contour of the eyelid. Therefore, we give a shallow bite of the levator muscles and through the skin. Therefore, the side of the sutures and also the tightness, not too loose, not too hard, not too firm of the sutures is matters. Therefore, in each sutures, it gives you even normal force, and then you get a good ptosis. This is immediate after the operation. This is 1 week, still some swelling. And then this 2 weeks, swelling gone. Therefore, it's good for the off stitches. Okay, therefore, in 2 weeks, you see there's no wound, just 3 sutures. Therefore, we take off the sutures. Therefore, doing the silk suture is good. You see, I leave behind quite a long sutures. Therefore, in case in post-operation, you find there's some deformity of the contour or you want to adjust, this you always can loosen these sutures and adjust the contour of the ptosis. Therefore, this is before and after the operation. Good ptosis correction means height, good contour, and the eyelash. Thank you very much.
Thank you, George. That was really interesting. So, I mean, during the posterior white line, when you ask the patient to open their eyes intra-op, I find it very hard to really assess the height. Even just now when you were showing, it looked undercorrected. So do you have this difficulty?
It depends on your sutures.
Okay.
Okay, if you are using 4O silk, white is quite thick, it will always increase the height after 2 weeks. Therefore, my aim is about 2 mm to 1 mm, not less than 1 mm under limbus, not more than 2 mm under limbus. Usually we give a good fit. Therefore, after a tight, I push all the conjunctiva inside the eyelid and then pull down with some cold gauze, and then you have a good guess.
And if let's say intra-op it is undercorrected, you will catch more of the levator. Is that right? How do you adjust intraoperatively with the posterior?
Usually we will adjust the force of the sutures.
Yeah, because you've really caught.
Therefore, in some case, if you want, you can. In some difficult case, you need to rebind. Maybe I will put it in the posterior side of the levators. But for most of the cases with good levator function, usually it's okay.
Okay. And what is the recurrence rate? Because I also started doing posterior white line for a period of time when Raman Malhotra came. But after a while, I found that the recurrence rate was too high for me to accept. I don't know, maybe my experience is wrong or different. What do you feel?
It depends on the suture you use.
Okay.
The techniques. Therefore, the first is actually sometimes silk suture gives you more scarring. Therefore, you get a deep, dynamic, and then good attachment. In my case, actually, the recurrence rate is very low, less than 10%.
Okay, interesting. Yeah, it's the first time I'm hearing about silk sutures. Usually they use Vicryl. Yeah, and I feel that the recurrence rate is way
It's not thick enough, not strong enough. And then silk can give you a scar down effect. Then you take it improving, and then sometimes what we are afraid about is the pitching. Therefore, if that happens, you can loosen the sutures, and then it can be adjustable.
Interesting. Thank you for sharing.
Thank you, Dr. Stephanie. May I also request Dr. Alice to give her input? She's back with us now.
Yeah, can you hear me now?
Yes, perfect.
Yes.
Okay. Yeah, thanks, George, for sharing this technique. Because I do quite a lot of white line. I think maybe the main difference is that I don't use silk suture, so there's something different. And I see that you only remove the stitch 2 weeks after. Is that the reason you wanted more scar tissue to form first before removing the sutures?
Yes, definitely. We see the liquid stiffen with time.
And I see that you only choose patients that already have existing crease. Is that right with this method?
With this method, usually for all ptosis surgery, if you are good levator function, you always give you good results. Therefore, for poor levator function, sometimes it's more difficult. Yes.
No, what I'm saying is that patients with what I can do is patients without a crease, then when I do a posterior white line, I can actually I can also create a crease by leaving the suture behind. Yeah, so that's why I don't have to remove the stitches. So then it's almost like a combination of a white line ptosis correction as well as a buried suture technique where you leave the suture behind, and that suture, because of that levator attachment to the tarsus and to the skin, you actually form a crease as well. So that's why you can combine the ptosis correction and creating a crease at the same time.
Yes, what I want to share with you my techniques is first, the silk suture is adjustable.
Okay.
And the second is 2 weeks with the scarring. Actually, the recurrence rate is very low.
Okay, I shall try that. Actually, I will try that using silk suture.
Thank you, everyone. May I request all of us to just take a quick picture before we go to the next case? So this is session.
We'll ask Kelvin also to log in if we can. Yeah. Is Kelvin there?
Hello, can you hear me?
Yes. Yeah, we want to see you.
Sorry. Oh, well, I'm a little bit I'm dressed up, but I'm in a little bit crowded position. I'm in a dinner meeting myself with my team, so I really enjoyed the discussion, and I'm very pleased to know that I do not have a lot of cosmetic practice in my current practice now, but I do appreciate the opportunity, and I'm very proud of the speakers as well as this discussion that brings in a lot of tips for the audience to understand how oculoplastic can be both precise, and that's the theme of this, isn't it? Perfection. I think I need to congratulate Malene and in organizing this precision and perfection for athletics. That's my real point. Thank you.
Thanks,
Thank
Kelvin.
you. So a quick picture, everyone, for just
Yes.
1 second. Okay, got this. All right, so may I request our next speaker, Dr. Viviana Cho, to speak on the dual solution of Asian eyelid, root Z epicanthoplasty meets epiblepharon repair. Over to you, Dr. Viviana. Yes.
And can you hear me?
Yeah, your voice is a little low.
Oh, okay. Oh, volume up?
Now better.
Yes.
Better,
Okay.
yeah.
Yeah. Thank you for inviting me to speak at the AIOS International Ophthalmic Conclave 2025. It's a great pleasure to join you all virtually. Okay. Epiblepharon is a congenital lid anomaly occurring at the margin of the upper or lower eyelid at the level of the horizontal skin fold and orbicularis muscle. It usually affects the medial half of the lower eyelid and occurs bilaterally. The excess skin or orbicularis muscle overrides onto the lid margin, directing cilia towards the globe and ultimately causing corneal irritation. The epicanthophore is a semilunar skin flap that descends along the side of the nose from the upper lid to the medial aspect of the lower lid. In East Asian, medial epicanthophore is frequently found. During epiblepharon repair surgery, there is a possibility that the epicanthophore may shift downwards, which can lead to unfavorable cosmetic appearance, and the patient's parents might complain to you about it. To resolve this concern, I combine epiblepharon repair with epicanthoplasty. Here are photos of surgical procedures. At first, draw a root Z-shaped incision line at epicanthus. You can see 2 points in photo A, and then skin incision with sharp number 11 blade is made. In photo B, undermine the tight preceptor orbicularis muscle freely and rotate the inferior apex point to the medial apex point, as you can see in the photo C. I usually close epicanthoplasty skin first to keep that shape. You can check it in the photo D. And incision design for epiblepharon repair is drawn extending to epicanthoplasty connect together. And the photo E and F, after skin and orbicularis muscle excision, rotation suture is applied. I prefer the rotation suture technique than modified Hodge operation. Hodge technique simply removes redundant skin and overriding orbicularis muscle, followed by skin closure, but sometimes epiblepharon recurs. Rotation suture is more definite technique to rotate the cilia direction outwards by anchoring the pretarsal orbicularis muscle to the tarsal plate and shows less recurrence. I usually apply at least 3 interrupted suture with 6-vicryl. In photo F, you can see the muscle hook to confirm tarsal plate tissue for rotating suture. Photo G is showing right after the rotation suture are applied, but there is some dog ear at the lateral side. In photo H, you can see additional skin excision design to remove the lateral dog ear, and the final skin suture is done in the last photo. Those are final comparisons. The upper photos show pre- and post-operative results of epiblepharon repair without epicanthoplasty, while the lower photos include epicanthoplasty. The difference is clear. Adding epicanthoplasty creates noticeably larger and more open-looking eyes. Patients and their parents would be very happy with the results. It is like killing 2 birds with 1 stone. This approach brings us closer to achieving precision and perfection for function and beauty. Thank you for listening.
Thank you, Viviana. So, well, that's interesting. I've never done that procedure actually. But you talked about rotational suture. I actually do that, but you didn't talk about where you anchor the tarsus. Do you anchor it to orbicularis?
I anchor the pretarsal orbicularis oculi muscle and
To
to
the
the tarsal plate, usually medial part.
Okay, I think
Uh,
that's an important step as well, to prevent recurrence. Now, in terms of measuring the root Z-plasty, can you go through the measurements again? Because that went by very quickly on how you measure how much skin to rotate.
Because aging is very from very young and to the adolescent too. So I usually measure 2 millimeters. I think it's a standard, and at least I do the 2 millimeters. And according to their face, sometimes I go through more, but no larger than 3 millimeters. So I just put a little bit more incision, and so I starts from the 2 millimeters usually.
Okay, and then you just pull it to assess if it's enough.
Yes.
Okay,
Maybe you
thank
can
you.
use the golden ratio to do the assessment.
Yeah, you can try to
Thank you
measure.
so much.
Good point, Ali.
Yes, thank you so much. And we will go to our last case for the day by Dr. Hin. And the topic is result of blepharoplasty combined with eyebrow fixation and one incision. Over to you, Dr. Hin.
So do you see my presentation?
Yes, Dr. Hin.
Yeah, hello everyone. I'm Dr. Tu Yen from Vietnam. First of all, I would like to thank you to Dr. Milin and Dr. Kasturi who invite me to India Automobile Society. And sorry. So today I would like to talk about my presentation result of upper blepharoplasty combined with the eyebrow fixation on one incision. There are no financial conflict of interest to disclose. So I would like to show some case report. The first case, a female patient, 82 years old. She had visual acuity good in both eyes, 20/30. She complained about problem associated with the reading book. She feels very heavy around eye and easy to tired after reading book for a short time. She also have a restricted range visual field in the superior gaze, but she feels better. Her symptom feel better when she used her hand to raise her brow up. And you can see some wrinkle in the forehead because of she always use the wrinkle to raise her brow. And she have diagnosed brow ptosis combined with the dermatochalasis. And the second case, a male patient, 65 years old, with the visual acuity good in both eyes. He feel restricted range visual field in the superior gaze, and he also feel unconfident because of his brow shape a little bit horizontal. And the main complaint is a cosmetic problem. He have diagnosed brow ptosis and dermatochalasis also. So you know that the edge degeneration in eyelid can occur with dermatochalasis, with or without with the brow ptosis. With blepharoplasty, we can reduce amount of skin redundant. But for the brow ptosis, we can use the brow lid fixation through the skin incision. But with patient come with the both combination symptom like dermatochalasis and brow ptosis, we can combine two techniques. But if we use the two incision, we will get more scar for the patient. So the option for this situation is combination in one incision. And this is a surgical procedure. First of all, we make the skin incision and remove the skin redundant and make the expose the periosteum and fix the eyebrow to the periosteum. And finally, we close the suture. This is a conclusion for the technique. Patient have a abnormal brow shape and position and have a dermatochalasis also. And she complained about the abnormal of the visual field. And then we make the skin incision and fix the brow to the periosteum to make the normal position of the brow. And this is result after operation. We can see that the wrinkle of the forehead is almost disappear, and the brow shape become normal. So the outcome for the first patient, and this is a post operation after 1 week. We can see the double fold is very clearly, and for this patient before operation, we can see that the real eyebrow eyelash is proceed, and she make the tattoo to make the normal of the eyebrow position. And after 1 week post operation, and this is 3 months post operation, and we can see that the crease very clear, and the patient very satisfied with this result. And the second case, this 1 week operation. So about this technique, we can tackle with the amount of skin redundant, and we also fix and adjust the shape of eyebrow. And with the combination of 2 techniques, we can reduce the scar for the patient, and also protect the supracochlear and supraorbital nerve and vessel. But anyway, it's a difficult technique. And this is more option for surgeon to fix the position of the eyebrow and also reduce the dermatochalasis and skin redundant. And it is safer combined with the open eyebrow fixation through the skin, but it's a little bit difficult when we expose the periosteum and fix the eyebrow to the periosteum. And this is effective for not only for the function but also for the cosmetic. And thank you for your listening.
Thank you, Dr. Yuen. In the interest of time, may I request Dr. Helen to give quick inputs on the discussion?
Okay, Hien, a wonderful job with great presentation. I think we've been looking forward to your topic from Dr. Millen and Dr. Yvette, right? From one incision, how can we do the brow lift? Do you think it is possible, or just the prevention of the brow descent after blepharoplasty?
Yeah, I think it's very interesting question, because for the some first cases, we found very difficult to fix how to fix the correct position of the eyebrow. And finally, when we make the correct position of the eyebrow, we fix by the needling through the skin to the periosteum to mark this position. And then when we expose the periosteum through the skin incision, we found where the needling and fix the suture to the periosteum to the with the eyebrow subcutaneous layer.
Yes. So in summary, at least you did some kind of brow lift effect, because there is no descent of the brow after blepharoplasty, even for the severe dermatochalasis patients. So I think it's a kind of good tip. And if you want to really elevate the brow with the transcutaneous incision, based on my experience, I could insert a bioabsorbable implant to fixate the brow tissue to the periosteum. For example, endotyne, it is made of PCL, but it absorbs by time. Or if we make the kind of dramatic elevation of the brow the pretracheal endoscopic brow lift will be a good option, right? I think even through the brow incision or transcutaneous incision, as far as I guess, we can prevent the brow descent. Or if we put some kind of fixation sutures like Dr. Hien did, we can do a little minimal brow elevation effect or maintaining effect after severe dermatochalasis patients.
Thank you. Thank you, everyone. May I request Dr. Millenard to give us summary conclusion and the closing remarks. Over to you, Dr. Millen.
Rolika, I'm going to ask Kasturi, our president, to make the closing remark and hand it over to the next session.
Thank you.
Kasturi.
Before we end, I should introduce Dr. Rolika. So Rolika has done her fellowship with Dr. Honovar in ocular oncology, and now she's in San Diego with Dr. Don Kikawa, recipient of numerous awards, including one of the most prestigious AIS award is the Colonel Rangachari Award. Very brilliant, very dynamic. Thank you, Rolika, for being with us today throughout the session. And before I conclude, I'd like to thank each of the faculty, all panelists, everyone presented wonderfully, so much of learning points. And I believe that every day is a learning day for all of us. With this, I once again thank All India Ophthalmological Society and the Asia Pacific Society of OPRS for having such a wonderful session, a great learning, great discussions, and also a very good night to all of you. Thank you.
Thank you,
Thank you, everyone.
Thank you.
Thank you for joining from all different timelines. It means a lot. And a very good night to the ones who are just about to sleep, and a good day to the rest of all of you. And we will be moving on to our next session on perfecting ptosis surgery tips and tricks. Over to you, Dr. Rituja.
Yeah.
Thank you. Bye-bye.
Bye, everyone.
Bye.
Bye.